And thank you. When I and several of the other officers, Lynn and MJ and Joyce and a few others started in January, it was sort of like swallowing a fire hose. People just couldn't believe all the stuff going on and all the stuff coming down the road. So we really appreciate you being here, and we need one another. The community is really important at this time. So we're going to go over the healthcare system, specifically as it relates to Hancock County residents. We will address, our panelists will address the ability of care, quality, and affordability issues. Topics they may want to touch on are hospitals and financial stability, insurance, Medicare, Medicare Advantage, Maine care, elder care, and the loss of nursing homes in this county. MAHA and the Northeast Public Health Collaborative, the roles and importance of state legislatures and in helping to safeguard our heritage. So if I can ask our three panelists to come up, we're very fortunate. We've got three very knowledgeable and experienced people in the medical field. And I told them whoever sits closest to me will be the first one to start. So David, it's like musical chairs. Sort of our agenda will be that I'll introduce each one of them, hand them the mic, and then they will speak for 5 minutes. And then the next person will speak for 5 minutes, and the third person will speak for 5 minutes, giving their perspective on these issues. And then we'll allow them to respond to one another for about 10 minutes. And then we're going to have you and the 20 or 30 people on Zoom that are joining us to jot down their questions or comments in the chat. And we'll get that information for you. And somebody is now looking at me like she has something to tell me because she's one of the tech gurus. It wasn't close enough. Yeah, for the three panelists and for anybody who asks questions, I'll warn you that you really need to hold the mic right up here to speak so everybody can hear, not only in here, but on Zoom. So please remember that, or somebody will come in and put it up closer. And George Schelling has volunteered, or maybe we volunteered him, to bring the mic around for the questions. So, I do want to say, before we really begin, that there's an awful lot going on politically in our area, throughout the country, throughout the state. And one of the big things that I'm really pleased and proud about, all the candidates running for Senate, all the candidates running for governor, they're out campaigning for no on one on the first ballot. They're really working hard, all of them. They're running against one another for the offices, but they're running to help democracy so that people like you and I can have an absentee ballot, and people that are older or infirmer and that sort of thing can vote by absentee in the future elections. That's really important, and I'm so proud of we've got our the executive director of the Democratic Committee. Devin has been out this last weekend. Imka, our vice chair from our Democratic committee, has been out campaigning. Just a lot of people. We've got signs at our office at 53 Church Street at Hancock County Democratic Committee, and buttons and all sorts of things. And now I think we've got 7 days a week volunteers from 10 until 2. So that if you need to get signs, if you want to find out something, there's somebody at the office. There's also the phone number you can call up and get that. On the 16th, we have another meeting. We try to invite candidates that are running for office to come and speak for 15 minutes. We've got Jordan Wood next on the 16th, and Angus King III are both going to come, one for Senate, one for governor. We try not to get 2 for Senate and 2 for governor at the same meeting. We don't want to do that, but we don't want to forum on it yet. So that we're really doing that. And plus, Ann Luther from League of Women Voters is going to speak to us on the whole the background and the meaning of ballot one, about trying to get rid of so much of the absentee ballot. So stay tuned, go to Hancock County website. There's so much there that not only that we're promoting, but other groups as well on the events and activities. And I can't say that I'm super proud of the executive committee and all the volunteers that are involved in Hancock County Democratic Committee. It's just amazing. I really give them a hand. It's really important. Okay, David Jolly. David is vice chair of the Maine AllCare Board of Directors. Maine Care is a statewide organization promoting the establishment of public-funded health care coverage for all Maine residents. David retired after 17 years of teaching in the Department of Public Health Education at North Carolina Central University, where he was involved in numerous prevention research projects related to HIV/AIDS, tobacco, and cancer. He also designed and taught a public health policy course focusing on access to health care. So he's got a rich background, and David, we're glad that you're here.
Good evening. Nice to see you all, and thank you for this opportunity. Really appreciate it. So Charles told you what our mission is. It's always been that, always will be that. We believe that a publicly funded system of universal health care is the only real solution to all the problems in our rapidly deteriorating healthcare system that we're going to be talking about tonight. We would prefer to see universal health care at the national level, but that isn't going to happen anytime soon. So for the last several years, Maine AllCare has been working on a state-based plan for universal health care. And we introduced legislation this past legislative session to that effect, to get that plan put in motion. Didn't go very far, but we introduced the discussion and we hope to keep it going. Having said that, Maine AllCare also recognizes that these are really extraordinary times. The threats to the healthcare services that we still have, threats from large corporations and from the administration in DC, are real and they're extreme. And therefore, this year, and maybe for the next few years, Maine AllCare will also be doing what we can to protect and preserve those services, however flawed and insufficient they may be. We need them. So that's enough about Maine AllCare. Tonight the topic is healthcare in Hancock County, so I wanted to throw out a few facts. So 13 of 16 Maine counties have been designated health professional shortage areas, and Hancock County is one of them. No surprise there. Healthcare facilities have been closing. You know that there are no nursing homes left in the county. 10 out of Maine's 24 rural hospitals have been designated as at risk of closing, and 2 of them have been designated as at immediate risk of closing because of the Medicaid cuts in the Republican tax law that was passed this summer. And those 2 hospitals are Aroostook Medical Center in Presque Isle and Maine Coast Memorial Hospital. Medical closures so far in Hancock County this year, the birthing unit at MDI Hospital, the primary care clinic, Northern Light Primary Care Clinic in Southwest Harbor, and just announced in the past few days, the Maine Family Planning Center in Ellsworth. About 12% of Hancock County residents between the ages of 18 and 16 currently have no health insurance whatsoever. That's more than 3,000 people. And probably twice that number are underinsured. And that means they have health insurance, but they still can't afford health care because of ridiculously high deductibles, copays, and other out-of-pocket expenses. more than 4 out of 10 households in Maine, I'm not sure the figure for Hancock County, but 4 out of 10 households in Maine have medical debt, which remains the #1 cause of bankruptcy in the United States. And a further threat to accessibility and affordability of healthcare around here are the ongoing battles between insurance companies and hospitals. Think Anthem and Northern Light. MaineCare, our state Medicaid program, estimates that 31,000 Mainers on Medicaid may be disenrolled within the first year of the rollout of Medicaid cuts due to new work requirements alone. And not necessarily because these people aren't meeting those work requirements, but rather due to verification barriers. And more will be disenrolled because redetermination of eligibility for Medicaid for those people who received it when Medicaid was expanded has been reduced from an annual event to every 6 months. The last thing I'll say is that if the enhanced premium tax credits through the ACA marketplace expire at the end of this year as planned, the average annual out-of-pocket premium payments are going to rise by 114%, from an average of $888 this year to over $1,900 next year. And the lower your income, the bigger that increase will be as a percent of your total income. So I could talk about a couple of other things like Medicare Advantage and the threat of private equity takeover of our hospitals. Maybe we can talk about that a little later, but I'm going to stop here.
Thank you, David. I'm sure there'll be questions coming up. Next in line is Doug Jones. For 24 years, Doug was CEO of hospitals in New York and Maine, including 10 years at Maine Coast Memorial Hospital. While in Machias, he was employed by Eastern Maine Healthcare Systems as the Downeast Community Hospital CEO until it became independent. He has been a corporator for Eastern Maine and now Northern Light for over 9 years and has chaired the Maine Hospital Association Board of Directors and led the region's United Way campaign in 2006. He currently serves as vice president of the board of the Hospice Volunteers of Hancock County. Doug is now retired. Doug?
Thank you, Charles. I have never spoken for only 5 minutes. So in order to do that, I'm going to try to avoid any kind of political commentary at all. I'm actually going to tell you a story about my time at the 2 main hospitals. And focus on this Anthem and Northern Light battle. When I was at Maine Coast, Anthem came to me and said, "You are the most expensive hospital in Maine." I knew that wasn't true. So fast forward, I went to Downeast Community Hospital in Machias. Anthem came to me and said, "Your hospital is the most expensive hospital in Maine." And, you know, that's their strategy. And now they're saying that to Northern Light. That's their strategy. That's their only strategy. Now, the reason that we're having access issues is all about money. When I had a conversation with my chief financial officer here at Maine Coast one time, I said, you know, the biggest bills go to the people without insurance at all. I want to charge those folks what Medicaid pays. I don't want to pay them to pay top dollar. And my CFO said, that's going to cost this hospital $300,000. Are you ready to do that? We were already losing money, so I wasn't ready to do that. And and the problem is that I was telling Bruce earlier, I went to the Maine AllCare meeting because I believe everybody should be charged the same. I believe that Medicaid should pay the same as Medicare. I believe that self-pay patients should pay the same as Medicaid. But that's not our system. Our system is very unfair. It is broken. I hate using that term, but you know, I went from being a hospital CEO to a consumer of healthcare, and it's unbelievable. I go to Maine Coast now. I don't recognize a lot of folks there because a lot of them are travelers, people from out of the area, and those travelers don't come cheap. If you're a registered nurse, you know, I don't know the numbers, but I do know that they get paid a lot more than a staff nurse who lives here. It's not right, but that is what's happening to healthcare. It just costs too much to go to see a doctor. Hospitals cost way too much, and I guess it's hard for you to imagine that a hospital CEO might say that, but I believe it to my core. Hospitals just cost too much, and the reason it happens is because nobody wants to pay the full freight for what it costs to employ doctors, to have a modern emergency department, to have a state-of-the-art X-ray and MRI and CAT scan. Very frustrating. So Charles, if that's 5 minutes, I'm done. I could spend a lot more time, but I welcome your questions.
Well, if we have extra time, I'm sure we can fill it with a lot of stories and other comments. As you can see, we've got some really experienced, well-trained, educated speakers. Bruce Becque is an RN, got a BA in Human Ecology from the College of the Atlantic, a BS in Nursing at the University of Maine. Bruce began his nursing career at Maine Coast Hospital in Ellsworth in 1995 and has continued to work there ever since. He has specialized in surgical services, working both in the operating room and in the recovery room. During this time, he served for 7 years as chief steward of the Local 188 of the Maine State Nursing Association, the union, which represents nurses and social workers at Maine Coast. Bruce has been an advocate for universal health care, having started the Ellsworth MDI chapter of Maine AllCare in 2017. Bruce, it's the mic.
Thank you, Charles. I want to thank the Hancock County Dems for putting on this forum. And I'd like to thank the UU Church for giving us this space. And I would like to thank all of you for coming and showing up and expressing an interest in what's going on tonight. And if anyone's watching this remotely, hello and thank you too. Instead of speaking extemporaneously, I wrote a little something so I get all my thoughts down correctly. So I'm Bruce Becque. I've been a registered nurse working in Hancock County since February of 1995. I'm currently employed at Maine Coast Hospital, which is owned by the Northern Light Health System. I have to state at the outset that I'm not a spokesperson for Northern Light, and the views that I express tonight are my own and do not represent the mission, views, or opinions of Northern Light Health. That's the disclaimer, so I don't get in trouble. I wanted to participate in this panel because my work as a staff nurse for over 30 years has given me a ground level perspective on many aspects of the healthcare resources that are available to residents of Downeast, Maine. And although this panel discussion is focusing on healthcare in Hancock County, I also want to include our neighbors in Washington County because they make significant use of Hancock County-based services. I witness on a daily basis both the successes and the failures of the healthcare industry. My specialty is acute care. I've worked, as Charles said, in surgical services at Maine Coast since 1999. I'm proud to say that in this setting, I've been part of teams that have delivered essential and life-saving treatment to many thousands of people. I'm also aware of how precarious our healthcare systems are and how there are current and potential existential vulnerabilities to these systems. Not surprisingly, one could describe healthcare in Hancock and Washington counties as rural healthcare. I'm not drawing on any bureaucratic definition of rural healthcare. I'm describing an ecosystem characterized by limited resources that is trying to serve a population that is highly dependent on government-provided programs such as Medicare, Maine Care, and insurance policies that are heavily subsidized under the Affordable Care Act. Because of this, healthcare providers in Downeast, Maine do not have the luxury of serving either a large population of wealthy private pay patients or patients who are covered by generous employer-based policies. In today's politically charged environment, this reimbursement dynamic is making it very hard to support adequate, stable, and continuous delivery of healthcare that all of us in Hancock County need and deserve. It's already been said, but I'll just reiterate that I'm going to be transparent that I've been both an advocate for universal health care and the unionization of healthcare professionals. I'm a dues-paying member of the Maine State Nursing Association. It's not my intention tonight, I know the lines are going to be blurry and all that, but I don't intend to digress into arguments necessarily supporting the movements of either universal health care or organizing labor. I'm just trying to be kind of objective and, like I say, just provide the perspective of someone who sees healthcare delivered day in and day out. Thanks, and I look forward to our discussion.
We have planned for 10 minutes or so for these three panelists to kind of respond to what one another has said. And then we'll turn it over for question and answer from the audience. And those of you who are on Zoom, if you just write down your questions or comments in the chat, Suzanne, who's dealing with the Zoom, will read out those questions to you. So I don't know if you'd have some comments that you'd like to respond to what something one another said, but just feel free to do so for the next 10 minutes or so.
Well, one thought that came to mind, we've all said that rural hospitals are in trouble financially. And the reason that they are in trouble financially are several. But a big one is that rural hospitals have a higher proportion of poor, sick, uninsured, and Medicaid patients than urban hospitals. They therefore have to absorb the costs of more charity care, and they're being reimbursed at lower levels because Medicaid reimbursement is considerably less than Medicare usually, which is considerably less than private insurance. So that's a big reason. But another is that there are a whole lot of administrative costs associated with running a hospital that have to do with billing and getting prior authorizations, billing health insurance companies, getting prior authorizations from health insurance companies. And that is a huge waste of resources. If we could cut that down, as we would in a single payer system, we could save a whole ton of money that we could use to provide better care to a lot more people. Also, Doug mentioned the higher cost of traveling nurses and docs. And why do we have those? Because we have this huge shortage in this area. And there are numerous reasons for that, but among them are the fact that folks are leaving the field or retiring early because they're not getting to practice medicine the way they were taught to practice medicine, the way they want to practice medicine, because of corporate bosses who are telling them that they have 15 minutes to see a patient and that's it, and placing other pressures on them to do what they don't see as moral medicine. So just throw those extra thoughts out there. What
You've raised so many issues. You've mentioned prior authorizations. I should go back to what Bruce said, though, at the beginning of his comments, that I'm not here to represent Northern Light or Maine Coast. I'm here to represent my years as a hospital administrator and the frustrations that I experienced over so many years. One of the things that, and I should mention that my dad was an executive at an insurance company, so I'm not an insurance company hater. Not really. But when after we provide care at a hospital, insurance companies often say, would you send us the medical records because we think you've overbilled us. You've just charged us too much. And when that first started, we didn't have electronic medical records, so we had to copy paper medical records. And the folks in our medical records department would spend hours every day just copying paper. We'd send it into the insurance company. And 90 days later, if we were lucky, they'd say, yeah, I guess we agree with you. We'll pay you now. Well, if you go to any store, they don't say, if you're really happy with the product, pay us when you feel like it. You know, so that's what hospitals are up against. I just find it very frustrating to try to figure out how to do this. Now, Maine AllCare has a wonderful goal. When early on in my career, a good friend of mine had an opportunity to go to England to look at their healthcare system. And when he was there, he visited the business office. And it was I don't remember the size of the hospital, but it was something in the order of 600 beds. I said, well, how many staff do you have? Did they have? He said, well, 2. Well, at Maine Coast, I think we had 16 in the billing department, because you've got to have somebody that specializes in Medicaid, somebody that specializes in Medicare, someone that's catching all the complaints, about high bills. And 16 didn't always seem like enough. So, I am a fan of Maine AllCare. I believe that a single payer is the right way to go, but I think it's a very, very steep hill to climb. And I'm going to be involved in it at some point because I believe in it, but I guess it's time to...
Thanks, Doug. A big thing I've seen during my career has been the industrialization of healthcare. When I started in nursing school in the early 90s and as a nurse in the mid 90s, people did not refer to the healthcare industry. It's been very dismaying for me to live through this transition. When I started at Maine Coast, we were an independent, community-based hospital. I knew everybody in the building: housekeepers, physicians, nurses, administrators, and it was wonderful. And I'm going to pay Doug a compliment here. He was the CEO during the halcyon days of Maine Coast Hospital. Unfortunately, the economics, which were basically policy determinations on the national level, the economics of healthcare made it harder and harder for small rural hospitals to survive. The pressure, as Doug can attest to, the economic pressures just became unsustainable. And from my perspective, Maine Coast was in an untenable, we were between a rock and a hard place. We were either going to go bankrupt, run out of money, or have some larger corporate entity come and take us over. And that is what happened. And I went through a profound grieving process because we went from being a community-based hospital where we were taking care of our neighbors and family and friends to the corporate mentality descending from on high, implying that they had all the answers to do everything right. And these were people largely with not backgrounds in healthcare, but they have MBAs and degrees in human resources and blah, 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 blah. And it destroyed the culture that we had. And it was a big loss. We're not going to get that back. But if we can wrest healthcare out of the grips of corporate America, that'll be the start of what we have to do. And as Doug said, it's a big uphill climb. This is the way I visualize it. In the United States every year, there's a trough of money above about $3 trillion. Well, there's a whole lot of people who want to get their snouts in that trough and suck up that money. They come from the insurance industry, they come from the pharmaceutical industry, the medical products industry, you name it. And they're all looking to make a profit from it. That's the problem. The profits that all these entities are taking for themselves are taking away from your health care. The insurance companies, as we all know, the health insurance companies, they make money if they deny you health care. And this is what, as you can tell, starts getting me wound up. And just another thing to touch on what David said about, I would say, the expense of travel nurses. There's a shortage of nurses. Right now, there's a shortage of a couple thousand nurses in the state of Maine, and it's projected to get even worse by 2030. I don't know where these bodies are going to come from. There's a shortage of physicians who want to work in a rural environment like this. I once worked with an orthopedic surgeon who had friends in California, and they said, I'll use his first name and maybe you'll know who he is. They said, Craig, you could come out to California and work for 3 years and retire. What the hell are you doing working in Maine? Well, he was here because of quality of life. And it's great that we have physicians who want to practice in Maine for quality of life, raise their families, get to, hang out on Mount Desert Island, all that. But that's not the majority of physicians. So if I ran the world, for instance, we would educate physicians and nurses so that they would get their education without shouldering a debt burden that required them to go and get the highest paying job they can get. So there's a whole lot of different ways to attract this, but I'm sure all this is going to generate some conversation. So.
Wow, there's a lot to talk about. We all have our own personal experiences in the healthcare, illnesses and friends and family and that sort of thing, working in the healthcare or needing healthcare. So at this point, if you have a question, a comment to add to what's already been said, raise your hand and George will bring the mic around to you. And if you're online on Zoom, write it down in the chat and Suzanne will read it to us so that we can share it with the group and then see what kind of responses we get.
I have two questions. First of all, you all three have spoken about the extraordinary cost associated with, or the profit, excuse me, the profit bullshit of corporate America. And I know Maine AllCare had one bill that was passed, I believe, this year, dealing with a moratorium on private equity firms acquiring hospitals in Maine. So I'd like a little bit of explanation about that and why that's important. The second question is about the, hold on, I'm sorry, my brain. Just answer that one, maybe I'll think of the second. Or if all of you can address that, I'd appreciate it.
That was a plan. Thank you, Royce. So Maine AllCare helped develop a LD 985, which called for a 5-year moratorium on private equity acquisition of Maine hospitals. Why did we do that? Because private equity, the goals of private equity are incompatible with the goals of healthcare. Private equity is all about profit as high and as fast as possible. Then private equity firms dump that particular hospital and move on to their next conquest. But beyond that, private equity acquired hospitals provide lower quality of care and at higher cost. And there have been numerous studies that show this. So we wanted a 5-year moratorium. Before they passed the bill, the legislature whittled it down to a single year. So it gives them a little bit of time to develop rules to regulate private equity purchases of hospitals. I don't know that it'll be enough time, but there is a commission that has been set up to specifically look at what regulations are needed for healthcare transactions in Maine. And their first meeting is tomorrow in Augusta. So we're hopeful that they'll get to it. And they don't have to start from scratch. 12 other states proposed legislation this year to regulate healthcare transactions like private equity acquisition. And New Mexico passed an extremely strong law that will make it very difficult for private equity firms to do what they've done in other states, such as Massachusetts and Pennsylvania, where private equity companies have stripped hospitals of their assets, then declared bankruptcy. And this has led to the permanent closure of community hospitals in both Massachusetts and Pennsylvania. So we're trying to avoid in Maine, what has happened there. We'll see how it works out.
Was that the Steward, were they private equity?
In Massachusetts, it was the Steward Group.
And Quincy Hospital, which served a tremendous amount of South Shore people.
Low-income people, brown and black people. The other hospital.
Get you to use the mic so the people on Zoom can hear too.
Oh, yeah.
No, that's fine.
I worked in healthcare and hospice as a clinical social worker for nearly 10 years, but I was aware of Stewart at that time, and then was really distressed to hear how they just absolutely stopped doing anything with healthcare, and they're selling off the assets of the properties for whatever purpose is going to pay the highest dollar. And
If I can give one example of that, the worst example, some of these private equity firms buy a hospital by taking on a huge amount of debt, which they then put on the hospital, not on the private equity firm. And then they will sometimes turn around and sell the land that the hospital is on, so that the hospital then has to rent back the land that they occupy. It's cruel and unusual punishment.
And you know, as you were all talking, it made me realize that the problem is bigger than just hospitals and patient, consumer healthcare. I mean, it seems like in our history with Citizens United being that the corporation has more power than individuals. And we're seeing that roll out even further since this new administration. So, you know, it's a big problem. And I don't know, we have to change that as well, I think, because it's everywhere. And it's in insurance companies, you know. Insurance used to be a lot different. Everything used to be a lot different. So anyway.
Well, we're talking about for-profit organizations. How many of you, I'm going to ask you a question. How many of you think that hospitals are for-profit? This is a really well-educated group because most people think that hospitals are for-profit. And piggybacking on that, they think that hospitals, because they have high bills, have a lot of money. And, you know, looking at Northern Light owes over, I don't even know the number any longer, but they are losing money hand over fist. And conversely, again, this is my hospital CEO coming through, Anthem is for profit, and part of their every healthcare dollar goes to their investors, not to healthcare. And I think about that in so many ways. I think about what Bruce was talking about, the corporatization of healthcare. That money shouldn't be going to investors. It should be going to our nurses, our doctors, and the people that don't make a profit. Most of them get paid fairly well, but not extravagantly, especially in Maine.
This will sound naive, but I do feel that any attempt to wrest healthcare from the grip of corporate America is maybe not entirely doomed, but I wouldn't put any bets on it happening. And so it occurs to me, what would happen if we simply started doing something else? We have a bunch of doctors in earlier generations in our family. You remember how it used to work. Doctors would accept a chicken from, or 2 dozen eggs from a family that couldn't really afford them. And I am sure there are some idealistic young doctors in this nation. What if they simply, 2 or 3 here and there, got together just out of med school and simply said, we're hanging up our shingle. We don't have any expensive equipment, but we can share our knowledge. Come to us and just simply offer their services. It would probably be illegal, but what happens if we encourage people to simply do something else? I am certainly a person who would go to a young group of new doctors like that, or maybe some older ones. I would be their first patient. What happens if we just do something else? I think people would vote with their feet in a big hurry. The one problem is, so much of modern medicine has extremely expensive equipment, and a group of 3 or 4 kids just out of med school can't afford that. Just some thoughts about what I have said.
Well, it is a Steve Pill. I have 2 physician friends who are paid a monthly stipend by their patients. I don't know what the number is, but they get paid the same amount no matter how much care they provide to their patients. I love the idea. And the 2 people that I'm thinking of are just marvelous individuals. but I don't know how to get, I'm not a politician. I have no idea how to do what you said, but I love the idea.
You have to deal with the issue of the huge amount of debt that most young doctors emerge from medical school with. How would they pay that back? I mean, I had a good friend who, in her first year of medical school, after her first year of medical school, was already more than $100,000 in debt. And she ended up joining the Air Force in order to get the rest of medical school paid for, and then owed the Air Force 3 years. But yeah, I don't know. We'd have to deal with that before, yeah.
I'd like to respond to you. I've been a nurse practitioner for over 40 years, and I've worked for many different organizations. When you're providing health care to somebody, when you come in ill, one aspect of your care is the individuals you first meet, the nurses and the doctors who are going to do an assessment and try to figure out what's going on. But so much of modern medicine is not the individual who is doing the assessment. It's also the laboratory work and the diagnostic tests that need to be done. If you're the one with cancer, if you're the one with a bizarre illness, if you're the one with a tick bite illness, if you're the one with any number of tropical diseases that we see individuals come back with from all over the country and all over the world, then you're going to need certain blood work, you're going to need CT scans, you're going to need an MRI, you might need a PET scan, you might need special pharmaceuticals that are very rare for your particular disease. All this costs a lot of money because the research that was done to develop that equipment, and that equipment is now owned by 45% of the time private equity companies. People don't realize that in certain states like New York, 45% of all specialty practices are owned by private equity companies. When private equity company takes over a specialist practice, the cost of all the laboratory tests, all the diagnostic tests with various machines goes up a significant amount. So again, the diagnostic tests, the laboratory work, the context in which those occur are all nowadays owned by private equity companies, insurance companies, where profit is a factor. Hospitals might be nonprofit, but a lot of the tests and pharmaceuticals are for profit. So yes, we could have very altruistic individuals and you can actually have free visits, but your healthcare is still going to be very expensive until we address those other issues.
How do you forecast your budgeting? I mean, in Maine, because there's a limited number of patients, not like, like I moved up here from Jacksonville where the Mayo was there and several other large hospital groups. And so they basically, everybody was busy all the time. So how do you forecast your budgeting for the hospital, and how bad is the financial situation of the hospital here?
You got me. Well, I really honestly didn't find budgeting that difficult. But there are two sides of budgeting. One is the expense side and one is the income side. And the expense side, isn't that difficult. You understand how many people in every category, all the departments, and you can forecast what it's going to cost. Now, there are always surprises. When I came to Ellsworth, we didn't have an ear, nose, and throat doctor. We didn't have a dermatologist. We didn't have a couple of other things. And all of a sudden, voila, we had those practices. And so we were already over budget. Now, one of the problems in budgeting is it's easy to imagine how revenue could be increased. So I hate to tell you this story, but I was one of those CEOs that had to go to a doctor and say, 15 minutes, that's all you get with your patient. And one doctor said to me, with tears in her eyes, you're telling me that I'm below average in terms of the number of patients that I'm seeing over time. And I said, yes, that's the case. And she almost bawled and said, I have never been below average. So, you know, and that really affected me. It's the income side that's so frustrating. And so you can imagine what Northern Light is thinking on their side now. They know what their expenses are going to be, but what's our revenue going to be? And why doesn't revenue match our expenses? And so a lot of hospitals are saying, shoot, we've got to close maternity service because we lose money on maternity service. Maternity, you can't say, well, we're going to have 50% more patients. You know, that doesn't happen. So, you know, as a hospital administrator, I'd go to the primary care doctors and say, you have to order more tests and you have to see more patients. And that's how, you know, we balance the budget, because I can't get Anthem to pay us any more money. And Anthem has an advantage, because when, you know, you come to our hospital and they're not with a non-participating insurance provider, what's going to happen is the hospital looks like the bad guy, not the insurance company that said, we're not going to pay you anymore, so you're out of network. Sorry, I could get on, I guess I am on my soapbox.
I wanted to say a word about budgeting of hospitals. So in Maine AllCare's program plan for universal health care in Maine, we propose that hospitals could be put on much firmer footing with what's called global budgeting. And that is where a hospital would negotiate its annual budget with an appropriate state agency. And those negotiations would be based on some combination of factors, such as actual costs the prior year, actual revenues the prior year, the service mix that they provided, their patient population, the cost of their charity care. And those hospitals then would not be at the mercy of low Medicaid payments, charity care that they have to provide to people with no insurance, et cetera. And this may sound like a pipe dream, but it's not, because since 2014, Maryland has been funding all of its hospitals via global budgeting. And since then, not one Maryland hospital has closed, and the growth of hospital costs has held steady for the past 10 years. So it works, and it's possible.
You're absolutely right, David. That's how hospitals are reimbursed in Canada. Hospitals in Canada are not closing, but if you want to get an MRI, it might take a while, months, to get an MRI or a CAT scan.
Could here too.
It could here, yes. And you're right, David. It is happening, and as a consumer, I definitely see that happening.
Before I give this to you, also we're going to ask for maybe some questions from the Zoom people. I asked for an MRI, and it's scheduled in December. If I do it in Bangor, if I went down to Portland, it would be late January. So, you know, it happens here too. It probably could be even later.
I can top that, because my doctor wanted me to have an MRI, and the insurance company said no. She heard bruit in my carotid artery, and she spent a lot of time on the phone arguing with the insurance company, saying, does she have to have a stroke before she can have an MRI? Me. And they never changed. So how long of a wait is that? I've never had that MRI.
Hi. I wanted to talk to Bruce, or I just wanted to hear more about your work and what you've done. I'm a nurse. I'm mostly in abortion care, and I'm currently studying to be an advanced practice nurse as a CNM here in Hancock County. And but before that, I worked as a union organizer. And so one of the things that I think is the most exciting happening in healthcare right now is nurses organizing and collective power. And I'd love to hear you talk about your experience at Maine Coast in a union, working with other nurses and building that collective power, because I think that's one of the solutions to our problems is recognizing our, that power and thinking about this from a labor perspective and not just all of these other pieces, but the labor piece is really important.
Sure, okay, I'll do my best. When I arrived at Maine Coast, there was already a union there. It formed in 1988. From what I can tell, unions form when there's abuse from above. Workers band together when they're being taken advantage of, and they say enough is enough. And that's really the history of the labor union movement throughout the whole United States. And from the coworkers of mine who were the leaders of the union organizing movement at Maine Coast, that's what happened. They felt like they weren't being treated fairly. For instance, there wasn't a standardized pay scale. So a nurse with 25 years of experience was maybe earning what the new grads were earning because the pay, you know, the beginning salaries had crept up over time. There's a tremendous amount, going back to the 1980s, a tremendous amount of pushback against organized labor on the national scale. You know, we know President Reagan was hell-bent on breaking the Union of the Air Traffic Controllers. And those same conservative interests, I think as we see across the political landscape today, have gained more and more power. The pushback against unions has been extreme. Union membership nationwide has declined since the 1980s. It's tragic because on several levels, but the period of the flourishing of the unions in the United States corresponded with the rise of the middle class. It's just documented. There's no secret about that. And as we've seen since the 1980s, one element of the transfer of wealth to the upper 1% has been the attack on organized labor. Locally, my experience as chief steward of our union was kind of a mixed experience. It was very hard for me because for whatever reason, I would say the lack of support for organized labor has been significant, even within the nursing union, for instance, at Maine Coast Hospital. People resent paying union dues. They say, what do my dues get me? I don't see anything. And these are people who have a pay scale, they have vacation pay, they've got health insurance, and benefits they would not have were it not for that contract that we have. But say they grew up in a family where the sentiment against organized labor was strong, so they adopted these views from their parents, and they've carried that with them into their adult lives, and they've walked into a situation where they have these benefits, and they don't realize that those benefits were won through unionization. So fortunately, throughout the country, the largest labor union in the United States is the largest union representing nurses is called National Nurses United, and there are some 700,000 or 800,000 nurses throughout the country who are part of bargaining units. National Nurses United has made great headway in expanding unionization throughout the country, even in red states like Florida, for instance. It's an uphill battle. The pushback is even getting stronger because of, well, for instance, during the first Trump administration, he and his cronies were putting appointees on the National Labor Relations Board that did not support the mission of the National Labor Relations Board. They were trying to subvert the mission. And that's only gotten worse since then. So it's an ongoing struggle. Yeah, I mean, really, that's the best I can say. It's an ongoing struggle. Is there anything else particular you wanted to, any other angle on that you were curious about?
No, I guess I was interested and excited to hear what you had to say, and specifically in that context. And do you think there's a room for nurses unions and more like collectivity in the future of healthcare? And do you think that would
absolutely.
help
Sure.
solve some of our problems?
Yeah, it all comes down to activism, though, and there's this dynamic between complacency and activism. A lot of people are just complacent. They're willing to accept their lot in life, their working conditions. That's actually kind of a codependent thing that happens with nurses. Nurses pride themselves on working hard and being able to take any level of abuse that can be thrown at them. So that works. Our own culture works against us sometimes. But like with any labor movement, sure, there's plenty more progress that can be made.
Before we go to you, I'm going to see if there are any questions. A wealth of knowledge just right in here, but from the Zoom can you read them? Or?
Yeah. Hi, we've got a question here addressing the steep cost of education. Do states sponsor nurses or doctors, helping them pay for some of their education in exchange for service in the state that sponsors them?
Absolutely. It's we all know that Maine is an aging state, and our nurses and all of our practitioners are aging, and when we look at people entering healthcare careers, they're wondering, how are we going to pay for it? And so it took hospitals and administrators like me a long time to figure it out. But when we finally figured it out, if we pay for people's education, they're going to want to come and work for us. And so it is working. What you see is hospitals and other entities are starting to step up to the plate and sponsor people's education. Bruce, I don't know if you have any.
Do you know if the state itself is paying for the education of healthcare providers?
I think the answer is yes, but I retired over 10 years ago, so I don't know.
Make me out myself here. Okay. I'm here in an unofficial capacity. I'm from the State Office of Rural Health at the CDC, but I'm here, like you said, disclaimer, I'm a resident of Bucksport. I knew you when we were both younger. I'm Asulia, I'm Valerie's daughter. So, okay. I'm Paula Key's friend. You all know Paula. Anyway, yeah, we have student loan repayments. It's quite small in comparison to the need. And I've been there for 2.5 years. We spent a lot of time looking at what you just said, that the aging population ratio. Right now, our student loan repayment program is funding mental health professionals, and it's just not enough. It's just not enough. I probably should mention the $100 million though, shouldn't I? So you all know about the rural, okay, again, from Bucksport, not Augusta right now. In the big beautiful bill, there's the $50 billion rural health money. CMS put out the grant application 3 weeks ago. Each state has to prepare a grant application for $100 million a year for 5 years for rural health transformation. So right now, MaineCare is the lead agency on that. It's a really complicated mess, and I like what you said about the trough because it's been pretty brutal. The amount of people who think they are now experts in fixing your rural health system that come from AI, come from Mass General, come from Epic Medical Record, everybody, it's been discouraging, and it's been both. It's like this huge opportunity to do global budgeting and some really creative financing thing, and then you're kind of trying to push away the vultures. But that's why I'm here tonight, to listen to y'all. I did tell some people from our office I would be here now, so thank you. And thank you for coming, and thank you for caring, and thank you for, just keeping up the fight.
So this $50 billion sounds like an awful lot of money, but it was what was stuck onto the tax bill that passed this summer after they cut $1 trillion.
It's amazing, and thank you for outing yourself. Are there other questions from the Zoom? I just want to be fair to some of the bunch of people that are there. There's an unbelievable wealth of information and experience in this room. I'm really kind of amazed with all the sharing, not only the questions, but the sharing.
I have more a comment and then a question here. Comment from Edie, more focus on education to help with reducing risk, preventing disease conditions as much as possible. People can learn incentives for people practicing good self-care to the best of their abilities. Any comments on that?
There's no replacement for individual responsibility.
But if we're going to be serious about prevention, we have to let providers see patients for more than 15 minutes.
Or see them at all.
Okay, and a question from Hank. Question to the labor folks. How would labor negotiations go, better or worse for labor, if healthcare benefits were no longer part of the negotiation dynamic? Meaning now only negotiating for pay, working conditions, and retirement, and no longer linking healthcare benefits to employment as a job lock. Is that for some?
Would that be assuming that we had universal health care? It'd be a world different. Labor unions would have a world of difference. Yeah, yeah. Yeah, that's a question, but it'd be great to try if we had universal health care. Other questions here within George?
Thank you, David, for Maine AllCare, everything you do. There's been in Maine, we hear about Maine AllCare, but coast to coast, we hear this cry for Medicare for all. Can you help me understand, in a single payer world, is Medicare for all what the standard we should be going? And at the risk of sounding like a socialist, one of the arguments against the single payer system is the competition argument, that once there's a single payer, then the insurance company's impetus to be in the business of not paying claims will get worse, and paying less and less will get worse because they're the only game in town. I'm not persuaded by that completely. But there's Maine AllCare and there's Medicare for All. So can you talk about what that really means in real terms?
Sure, there are a couple of things there. First of all, in our plan, we would essentially be doing away with private health insurance. There'd be a single payer. It would be the state, okay? All bills would be submitted to one agency at the state level. What Maine AllCare is advocating for is improved Medicare for all, because we would like to see Medicare for all that includes dental, hearing, vision. And our plan, we contracted with God, I'm going to forget the name of it now. MESEP, the Maine, can't remember what MESEP stands for. Anyway, they did an economic analysis of our plan and decided that their conclusion was that for about the same amount of money as we are currently paying for healthcare in Maine, we could cover everyone with an improved Medicare for All program. So, did that answer your question? Okay.
Hello. MESEP is Maine Center for Economic Policy. My question is, what advice do you have to us in terms of what we can do and Mainers can do to help support and promote Maine AllCare?
So this commission is meeting right now. We're going to start meeting tomorrow that will be considering regulations for private equity acquisition of hospitals. So people could write the commission and say, we want to see this strong, strictly regulated so that the situation with hospitals doesn't get any worse. But in terms of universal health care, we had two bills before the legislature this year. One was essentially would have implemented the All Maine Health program that we developed. And the accompanying bill would have told the state to conduct an economic feasibility study of our program. Because we realize we can't expect the state to do this unless they see that it's economically feasible. And we didn't think they would take our word for it or MESEP's word for it. Neither of those bills were reported favorably out of committee. But this gets a little complicated. But there are these open bills that can be filled. They're empty bills right now, and the powers that be that in the legislature could fill them with requests. These are healthcare bills, could fill them with requests for that economic study, for instance. So we would love to get that through. We didn't expect to get the All Maine Health program through this year. We just wanted them to be talking about it and hopefully see that it would be a good thing to at least study. But they didn't even agree to the study. So we're still pushing them to do that. And we would love people to support us in that effort. It's the Healthcare Insurance and Financial Services Committee that heard our bill. And there are these two empty containers that they could drop that into before January.
David, could you put that in a simple written form so that we could send it out to everybody here? so that we could be motivated to do what you say without getting home and scratching our head and saying, now, what did he want us to do, and who do we send this to, and what do we do next?
I just remembered one other thing. We have a letters to the editor team that writes letters, sometimes op-ed pieces, to keep the issue of universal health care in front of the public. And that team is always looking for new members. So if you're a writer, we would love to sign you up. I have in the lobby there a sign-up sheet for Maine AllCare. And if you fill that out and check the volunteer box, we would be delighted to get in touch with you and talk about other ways that you can support Maine AllCare.
Seems like there's about 25 people in the room that could write letters for you.
David, on the Maine AllCare website, is there not information about what you've just been saying to tell people a call to action? So if you go to maineallcare.org, a lot of this information is there. And it used to be, I don't know if it still is, when you can write something on the maineallcare.org web, you can write to someone there and a real person will answer you. Is that still true? There you go.
I didn't think that still happened, that a real person would respond to you. I see somebody over here standing with a couple signs. Did you want to say anything?
I'm Lynn Gould. I'm spending a lot of time at the office these days, and we're staffed 7 days a week, 10 to 2, at least through the November elections. We're managing that. I did bring some signs tonight, brand new. We would love to have them go home with people rather than going back to the office. We pay about $5 a piece for them. We would love a donation, but we'd love more to get them out and seen.
Thank you, Lynn. 10 to 2, right? 10 to 2, yeah.
7 days a week.
Sure. There's another.
A couple comments and then a question. I've had heart problems for years. And I had a cardiologist in Bangor that I saw back in September of 2024. I was in Boston in December of 2024, had a heart attack, went to MGH, was told upon release 7 days later that I should make an immediate appointment with my cardiologist. Got back here, called the cardiologist's office. Yes, she can see you. It will be in January of 2026. Just having a heart attack and being advised to contact her. Number one. Number two, I have an excellent primary care physician who used to be at Ellsworth Internal Medicine when it was Maine Coast Memorial Hospital before Machias took it over. And he was told by someone that he only had 15 minutes to take patients. Well, he moved to MDI, as did about, I don't know, I heard a quarter of his patients went with him. I being among them. I live in Penobscot. I take an hour drive to see him because I know he will be late for my appointment because he takes as much time with everyone other of his primary care clients as he does with me, which can range up to an hour. Okay, MDI is a private hospital. A lot of money on the island, right, that's supporting them. So, I mean, that's a different story. Okay, just a couple comments there about our screwed up healthcare system here in Hancock County. The question I have has to do with Medicare Advantage plans. And this is not a plant for David again. I would like to know how those of you who have been in the profession of providing health care view, what did I just say? Medicare Advantage plans versus traditional Medicare and a Medicare supplement?
I'm not an expert on Medicare Advantage, but I've done a lot of research on it. And when you see the ads on television or wherever, they're not telling you the whole story. I personally, I thought I wanted to sign up for it because I could get dental and a bunch of other things. But those programs are, they're paying an insurance agent to sell you a Medicare Advantage plan. So that's leakage of healthcare dollars outside of the healthcare business. So I'm not a fan of Medicare Advantage, even though it sounds fabulous. But there is an expert in the room on Medicare Advantage.
You're the expert. I'm just a consumer.
No, I'd like to know.
Sure.
Yeah.
Okay. I turned 65 3 years ago and got on Medicare. I went to this guy in Southwest Harbor who tried to sell me a Medicare Advantage plan, blurring the lines, not making it clear to me what was Medicare Advantage and what wasn't. Because I was an educated consumer and a healthcare professional, I knew that Medicare Advantage plans were a backdoor way for the insurance companies to get more money out of the federal government. Another way to get their nose in the trough and suck some money out of there. Out of principle, I have a traditional Medicare supplement plan that costs me $200 a month. My ex-wife went for Medicare Advantage because she can only afford $50 a month. I say, but yes, you're confined to a healthcare a provider network that could come back to bite you. As a consumer, I don't like being confined to a network of physicians like Anthem. So this comes back to public policy. The insurance companies have gotten CMS to allow them to sell these policies to the consumer that are not equivalent. And even though they have advantages like dental and a gym membership and this and that, when it comes down to it, they're going to fight you when it comes to authorization. So a personal story, 2 years ago, I had to have my prostate out for prostate cancer on Medicare and my Medicare supplement. I didn't have to get one single pre-authorization for anything. It just sailed through. And I'm thinking, what the hell would it have been like if I had been fighting to, get an MRI or the PET scan I needed? I would have been really worried. So, that's just my personal experience. But, I feel like I'm unfortunately in a situation where I can afford the traditional Medicare supplement instead of just this bare bones safety net kind of thing. So that, that's a consumer's point of view.
Maine went from number of patients on Medicare Advantage to what the sort of average was to above average. We're at like 60, approaching 70% Medicare Advantage. Like we've skyrocketed like unusually high. And I do believe because they really see us as a place to make a lot of money. Yeah.
Nationally, more than half of all Medicare patients are now on Medicare Advantage plans. And it's the stated goal of the Trump administration to move everyone into a Medicare Advantage plan and do away with traditional Medicare. Bruce identified two of the big problems, narrow networks of providers, which has resulted in people with cancer who have Medicare Advantage plans being denied access to the leading cancer centers in the country. And then prior authorizations, Bruce gave a beautiful example. Prior authorizations is a way of making money. If they deny your authorization, that's less care they have to provide and pay for. And they, if you appeal a denial of a prior authorization, 86% of the time, ultimately the denial will be reversed and you'll get approved. Do you know the percentage of denials that are appealed? 11%. And that's what they count on. Oh, I was denied, can't do anything about it. Medicare Advantage plans were established initially because it was thought that this would be a way of controlling the growth of healthcare costs. Study after study shows that care is more expensive under a Medicare Advantage plan than under a traditional Medicare plan. That is an excellent question, because these companies are somehow making a profit out of it. I can't really explain it, but maybe somebody else here can.
I think, and this is not 100% sure, I think they are charging the feds more. So the costs are at, it was started to
That's right.
save money, but they're charging, and there's that star point system.
Yeah.
There's a whole lot of wheeling and dealing between these companies and
Yeah,
the
that
federal
was
government.
actually the last point I was going to make. The other big problem with Medicare Advantage plans is fraud. So Medicare Advantage is paid by the federal government to provide its patients with care for over a year-long period. But what they are paid by the federal government depends on whether or not they are considered a sicker or healthier patient. And so what these insurance companies do is they scour your medical records for any medical problem you've ever had to use it as an argument for labeling you a sicker patient, which will give them a higher reimbursement level. And 7 of the 10 largest Medicare Advantage plans in the country have been sued for fraud by the federal government and have been fined billions of dollars. But they make so much money on these plans that they pay the fines and just keep doing it anyway. If the government were really serious about it, they would say, you continue to commit fraud and you can no longer take part in this program. But they're not doing that. The fines sound huge, but compared to the profit, minuscule. Oh, and one last thing. In terms of traditional Medicare, the Trump administration is now hiring private insurance companies to test prior authorizations in traditional Medicare. Mandatory in 6 states beginning next year. Other states can adopt it on a voluntary basis if they want.
Wow. Is there a way to get it off of Medicare Advantage? You just do it this?
Each year there's an open enrollment period.
Okay. So you can go back from Medicare Advantage to Medicare.
December 1st? Yes, I think it is. It's
Yeah.
coming up soon.
Okay.
It will cost you more upfront because you'll have to get a Medigap plan and a drug plan, which you don't need with a Medicare Advantage plan, but could save you down the road. A piece. I mean, Medicare Advantage plans save you money as long as you're healthy. But when you get sick, then you start to pay the piper.
I came from Massachusetts, and when I was working in hospice, and of course people are dying, I heard many, many families say that their Advantage programs, boy, they sounded so good, but when they really got sick, that was a negative. I'm a resident here, and my doctors and I, when I was 70 or 65, 70, I signed up for a supplement. And I went with Blue Cross Blue Shield of Massachusetts, nothing to do with Anthem. So the Blue Cross Blue Shield is very state specific. And we in Massachusetts, they have a SHINE program that are counselors that are volunteers that meet during these periods of signing up for health care, or meet regularly at senior centers. And they're well trained, and they understand the insurances that might change and are offered. And they would never, ever be trying to push Advantage or one particular thing. They'd say, what are you looking for? And they have charts and what have you. I was hoping there'd be something up here, and all I see up here is Advantage. So I've been told to stick with my original Medicare that I've had for years, and I pay, I'm 77, I pay $260 for my supplement. I can go anywhere in the country for care, although I've not been able to find doctors up here that could take me, for Lyme or this or that. But what I'm concerned with is now with this administration, I'm forecasting that they're going to try to get rid of all the old people that have been grandfathered in, because original Medicare, I think in New Hampshire and Maine, any other state, may be quite different. And so there's a lot of inconsistency between states. And I worry that in the future, because I'm a resident here, but I could go anywhere, and I generally go to Massachusetts for health care. So anybody have experience with that, especially where there's probably a lot of older people that come here permanently and they carry portability, their original Medicare, their supplement. So it actually brings money into the hospitals if the staff was available to, I couldn't find a dermatologist who would even answer my call a few months ago. So I don't know, is any of that?
If I'm understanding your question, I'm going to tell you this, and I hope it helps you. In the state of Maine, there's, I hope I've written it right. It's EAAA, it's the Eastern Area Agency on Aging, I think. And I think it has federal money, and they're independent, and I have their phone number, and you can call them up and they will help you choose insurance. Yeah, I will do that for Part D. Okay. The other complication with original Medicare is that each year, like I took Blue Cross Blue Shield from Massachusetts for my supplement, but
knock wood, I'm pretty healthy without taking medications. So I went with the cheapest Part D that was available, and it probably, they change often. And so what I paid for $14 instead of $50 when I first signed up, that actually went away. It tripled. So it was a company that their strategy was that they would double it every year, kind of thing, which is it's bogus, right? And so I have to really pay attention. I'm healthy, knock wood, but if I was not healthy, it would be hard to maintain your original Medicare if you didn't couple the Part D part. You have to pay attention, and you have to be on top of the changes. I worry that even being healthy, I might not keep up with the interpretation of all these,
During open enrollment, you can ask all the questions you want, and they will just listen to you and
Okay.
keep answering your questions.
Yeah, good.
And they're there to help you
Okay.
impartially that way. I
Yeah.
can give you the number.
Okay.
Thank you. It is after 8:30, but we can continue on if we want to. I'm just saying that, if people need to leave, we were hoping to stay till 8:30. I want to say one thing. I think before we go, one of the things that I'm feeling stronger than ever after the panel and all the wonderful questions and comments that have been raised is that we really need as many activists in the state of Maine as possible. We need to stay together. We need to keep working, whether it's on protecting Maine's absentee ballot or working for MaineCare or working for the candidate of our choice that we feel is going to protect democracy and some of the rights that we feel are slipping away. So let's stay for a couple more questions. I think somebody had one.
I have one online.
Respond from up here.
I had a question. COVID wasn't so long ago, and it was a crisis, right, for hospitals and providers and nurses. A lot of people quit, right? A lot of people just got out of the system. So I wondered if there's still repercussions of that, or, what if we had another one? In our local hospitals, or
Well, repercussions, probably the biggest one was the massive loss of life across the country. Yeah, and I'm trying to, I don't mean to be glib, but many healthcare professionals did say enough was enough. The need to staff hospitals gave a large rise to this phenomenon of travel healthcare professionals, primarily nurses. But I was even shocked, and now there are travelers who do sterile processing and travel scrub technicians. Like all these subspecialties all have travelers now. And they filled a very important staffing need when it was happening during the pandemic. And I think that, this traveling phenomenon will always exist on some level, but of course, the travel personnel make so much money that hospitals are trying to minimize the reliance on travel staff. Retention is a big issue in healthcare now. The pressures are too much for some people. Whether it's a physician who's required to see a patient every 15 minutes, or whether it's a nurse who, all kinds of nurses get burnout for various reasons, but the pressures are very, very strong. And, there's no simple answer to that. But I tell you, I have two daughters, and if either one of them thought about going into nursing, I would say, well, it could be a great career, but. Whereas when I went into nursing, everyone just said, oh, it's a great career, no ifs, ands, or buts about it. But on the national level, of course, we know that the administration is not taking the phenomenon of pandemics or epidemics worldwide seriously at all. The CDC's teams are being dismantled, funding for research at the NIH is being dismantled. I mean, it's horrific. The whole infrastructure, the academic infrastructure for studying virology, for instance, at every level, our ability to respond is becoming weaker, and it will continue to get weaker if the people who are in charge now can continue to stay in charge.
Charles, can you hear me?
I'm always looking for solutions, and I'm so pleased to have heard some tonight. But as we go back into the big world and want to work for a better system, we've already heard some really good things. Strengthen the labor movement. Let's get AllCare Maine. Let's look at Maryland's plans for supporting their hospitals. These are things that could actually be possible. So I'd love to hear from each of you what you think is an achievable, something that could actually, you could work for it and there would be at least a possibility that it could work. Where are you seeing just a little crack of light, and where should we put our energy?
That's a great way to end. Yeah. Yes. Yeah. Why don't you
Pay attention to this 100 million and protect it for our state so that it doesn't go to computer companies from California. Pay attention. And pay attention to your legislators. You know, speak to them so they know what's going on.
And don't forget to vote. It's the most powerful tool that we've got. That's it. My glimmer of hope, I'm an internal optimist, and I just believe that we have to keep speaking about what our personal goals are and holding people accountable. You know, unfortunately, I fight with people every day on Facebook, and you know, but you know, I think it's important that people are held accountable, and we talk about no on one. Well, the League of Women Voters does an extensive research before they take a position, and they support no on one. So you know, I think we just have to keep spreading the word about what we believe, what's important to us, and don't give up.
My glimmer of hope is community. This kind of meeting we're having here tonight is a glimmer of hope. The silver lining to me, for me, after the most recent presidential election, is that I've sought out community more. And I'm really an introvert. It's easier for me. My state of inertia is not to be in a community setting like this. But on a personal level, I realize I would just kind of shrivel up in despair. And that, of course, would be, you know, would be horrible. So what I've seen, the level of organizing, the creative ways people have come together in the last 6, 8, 9 months has been very impressive to me. And yeah, that's it.
Well, I'm not prepared to give up on universal health care in Maine. And I think we have a model in Canada for getting it done. In Canada in the 1960s, one province developed a system for universal health care. That was Saskatchewan. That was so successful that within 5 years, every other province in Canada adopted it. So that could happen in the US too. And it's not just Maine that's working on a state-based single-payer system. There are 21 states that have organizations like Maine AllCare that are working for universal health care in their state. That will be made easier if we could regain control of Congress, a supportive Congress, There's a bill that could be passed called the State-Based Universal Health Care Act, which would greatly facilitate individual states developing a universal health care system. Introduced by Ro Khanna from California. Every year it gets more co-signers. So I hang on to that hope and will continue to work in community with others at Maine AllCare and other individuals and organizations on that.
Thank you all for coming. Thank you three. We could go on for another hour or so, but there's a lot to say. I just say on the 16th of October, we have our Hancock County Democratic Committee meeting right here, 7 o'clock to 8:30. We've got two candidates coming to introduce themselves, plus Ann Luther, who's going to come and talk about question 1. On the 18th, No Kings demonstration, City Hall parking lot. We need more and more thousands. I mean, voting is good, but until the elections come, we need to be out there in the streets. Thank you all. This community of people gathered, it doesn't have to be one organization, but we need to work together to strengthen one another and to try to survive this crazy administration that we have now and try to inch back to some sanity. Thank you so much.
You folks are all unmuted. You can unmute yourself if you have any comments among yourselves. You're welcome to chat for a minute. I'll stand for a few more minutes.